Okay, Keith.
All right, everyone. I think we're going to go ahead and start, guys. So for those of you who don't know me, I'm Chucky, or Dr. Davis in my formal sense. I'm one of the second years here. And this is Nikita, Dr. Goswami. She's one of our third years here, and this is her last general club. So we're going to send her off with a good one. And, of course, we have Dr. Jaimes, our pediatrician, that's helping us stay with our journal club. So first and foremost, do we have any disclosures? Obviously, you can see SpongeBob's wallet is empty. But I constantly get asked, you're a doctor, don't you have money? No. So this is a secret bill that no one tells others about that residents secretly have. So I constantly feel like I'm spending money that I don't have. So our article today is Melatonin Supplementation for Children with Atopic Dermatitis, also known as eczema, and Sleep Disturbance. And this is a randomized clinical trial. This was published back in January 2016 in JAMA Pediatrics. It has actually received a lot of high praise from multiple pediatric conferences across the country over the last year. So to start with our PICO-TT format, our patient population that's targeted within the study are children that are diagnosed with AD, which is what I'm going to use to refer to atopic dermatitis for the rest of the presentation as, that have sleep disturbance. The intervention that's being studied is melatonin in comparison to placebo. The outcome that we're looking for is to see whether melatonin is effective in treating sleep disturbances within this patient group. It's a therapeutic study, and thankfully this is a randomized clinical trial, which is the ideal type of study to do for a therapy study. So before we dive right into the actual study methods and results, just some quick points on eczema, or AD. Very common chronic pruritic skin disease, affects about 15 to 30% of children, and then later on about 10% of all adults are affected as well. So it's caused by an inflammatory process. So as many of the pediatricians in the room know, it's also associated with a greater risk of having allergic rhinitis and asthma. We know that as the atopic march. So sleep disturbance will occur actually in the majority of the patients, up to 60% that are affected by eczema. And at this time, there's no recommendations or any guidelines for how to manage patients that have eczema and sleep disturbance. So you might treat them separately from that, but there's no evidence to say that specific for these patients that one particular treatment works. So once again, just to reiterate, it is commonly managed with melatonin, but no evidence behind this, and there's no correlation that's been found. However, there was a recent study that was performed by the same physician that did this study back in 2014, and this was also published in Pediatrics. His study concluded that reduced nocturnal melatonin secretion was associated with sleep disturbance and a greater severity of disease in children that have eczema. So the basis of that study helped branch out to create the study that we're reviewing today.
Okay, so delve into our data. So the population that was included was anyone between the age of 1 to 18 years. They had a physician diagnosis of eczema. They had to have about 5% of body surface area involved to be included in the study. And from there, the patient had to have some type of sleep problem for more than 3 days a week over the past 3 months. So they define sleep disturbance as anything that involves trouble falling asleep or maintaining sleep that impair their quality of life or day-to-day activities for the child or the family members. Exclusion criteria included those outside of this age parameters, if they had less than 5% skin involvement, and if they had any prior diagnosis of sleep disorders or neuropsychiatric disorders that could have caused sleep problems, and also if anyone was already on any kind of medications for insomnia or any antidepressants. So the study was conducted at a large tertiary facility in Taiwan. The time period was between August 1st, 2012 to January 31st, 2013. And initially they had a 2-week pre-screening period where patients and family had to keep track of all these things. So they wanted them to keep a sleep diary, adhere to a fixed sleep schedule, and also avoid any drinks with caffeine. So the methods, the patients were, if they were already taking any medicines for their eczema or atopic dermatitis, like hydrocortisone, for example, they could continue these medications. And then the patients that were finally chosen for the study were randomized in a 1-to-1 fashion into 2 treatment groups, either melatonin or getting a placebo. So here's a timeline of the study. So like we talked about, the baseline visit, and they had their 2-week pre-screening where they had the sleep diary and everything. Then they were randomized into the 2 separate groups of melatonin or placebo, and they received those treatments for 4 weeks. After the 4-week treatment, they went through a washout period, as they described in the article, where they stopped the treatments, give them a chance to have all that medicine walked out of their body or the placebo, and then they went to a 4-week crossover study where they switched to the opposite medication. So they got melatonin first, they got placebo second, or vice versa. Here's a table of the flow chart of the study. So initially they had 73 patients that were eligible, and then 25 patients out of those became ineligible due to not offering consent or had subjective sleep problems improved before the enrollment. So there were 48 total that were actually included in the study and randomized. So there were 24 in each group. So each group did lose a few individuals. So if you look on the left side, you can see the melatonin group on the left lost 6 individuals due to poor compliance, changing their minds, or having other family members disagreeing with this research and study. So total, you ended up having 18 patients that ended up receiving the melatonin. And if you look at the right, where they started with the placebo, we lost 4 patients due to family members disagreeing or they changed their minds. So you had remaining 20 members that remained in that study. So then they had the 2-week washout period. You can see in the middle of the box where it says week 5 to 6, that's a 2-week washout. And then at the end, they switched groups for 4 weeks again. So the methods used, physicians' visits occurred at the start of the trial on the first and the last day of each treatment period. So atopic dermatitis disease severity was assessed using a SCORAD index, which they used in the study, and did urine and blood samples that were also collected. And we'll go into that a little bit more in the next slide. Additionally, a subjective questionnaire was given for symptoms, pill counts, any adverse reactions that may have occurred, and the sleep was monitored with an actigraphy. So I know many of you in here have a Fitbit. That's a form of actigraphy, so they basically wear a device on their wrist that monitors activity, and they record it over time. So you want to have repetitive recordings and kind of take the average, and they put it into a computer to pull the data out after. Interesting side note is usually if you're monitoring sleep, you want to wear it on your non-dominant hand rather than your dominant, because it gives you a better recording result. So in terms of the labs that were done, the urine that was collected was measuring a specific thing called 6-sulfathoxymelatonin via enzyme-linked immunosorbent assay, representing the melatonin level throughout the previous night. And then the peripheral blood samples were taken at 9 a.m. the morning after the last night of each testing period, and these were used to measure the serum total IgE and levels of the allergen-specific IgE specific to bacteria. So if the levels were higher than 0.35, they were considered to be positive. So the statistical analysis done in the study was a mixed effect model. So they compared the mean changes in outcomes before versus after the treatment between the melatonin and placebo phases. So the variables that they included in this model were the indicator variable for the phase, so whether it was melatonin or placebo, the time period, whether it was before or after treatment, the phase times the time interaction, and the sequence, looking at whether they had melatonin first or placebo first, and the switch. And then the period, so the before and after the crossover, and lastly, a carryover effect was defined as statistically significant. So those of you, if you were at our journal club back in December, we talked a little bit about fixed and random effects. So mixed effect takes a little bit of both of these and uses both to compare. So fixed effect is when there was an individual specific effect that correlated with an independent variable, while random effect had an individual specific effect that didn't correlate with an independent variable. So in this study, the mixed effect model were used to provide further evidence for any significance in the difference of treatment among the melatonin and placebo groups. Age and sex were adjusted for due to being a potential confounder, and due to the small sample size, they used a Wilcoxon-signed rank test to compare the difference of each outcome between the groups. A SCORAD index decrease of 5 was considered to be significant.
Okay, so we'll go ahead and talk about the results. Before that, anyone have questions about the methods? Okay. All right, so once again, in total, we had 73 children at the start of the study that were eligible. Oh.
background idea.
Mm-hmm.
So when children roll around all the time in their sleep, and that's when they sense more. How do they distinguish like their naked meaning? Was it just extract? I mean, how did they have a cutoff of some sort?
So it's one of the measurements they actually talk about is the amount of sleep movement within the study. And I don't know if there's a baseline or a cutoff that was mentioned, but just within the actigraphy itself, they can use a mean, and they just, I guess, compare them. I don't think they had a cutoff specifically for that, though.
Go ahead. You also keep track of your heart rate. So it can, it analyzes your resting heart rate, and then if you can wake up and move around a lot, your heart rate should go up. It learns your sleep habits
and funny enough, on the mobility, there wasn't a statistical significance before and after with the melatonin. I guess it's really hard to tell because it moves so much in their sleep. And, in all the analysis, placebo and, all melatonin and baseline data that they got in the first 2 weeks, and there was no difference. So I guess that's one of the things that...
If you ever stuck with the top.
Yeah, and I mean, that's actually why, and just from a side note, that in general, if you're wanting to really see accurately what your sleep is through actigraphy, you wear it on your non-dominant hand, even as adults, because we're more likely to move our dominant hands in sleep. So anyway, once again, 73 total children met criteria for the study, and of those, 48 were randomized into those one-to-one treatment groups. Now, something to talk about with the treatment groups. So that randomization occurred through a computer-generated model, and it actually happened in sets of 4. So for every 4 patients they would have, they go into the 0 group or the 1 group. And it would be blinded, so no one knew which one was with or without treatment. And then once the computer decided how many of each were there, the next 4, they would accommodate so that it was still even. And they would go through each of these. And that's how they made sure to keep them at 1-to-1 without anyone knowing who was in what group. So once they had started with phase 1, between phase 1 and phase 2 in the washout period, 10 of them had dropped out again, so we had 38 that actually completed both sides of the trial. The majority of the patients that we lost to the follow-up right at the start of the study were lost to refusal to consent despite meeting the criteria, so the 25 to 35. It's actually thought this may be a cultural issue specific to that area. Families, parents are not directly the ones that have decision-making. So even though a parent may be consenting for the study, if a grandparent were to come, the person that's eldest in the family may refuse. So in a lot of these studies, children are pulled out after they've been started by parents because the grandparents decide they don't want them in it, which is what we think accounted for such a large loss. However, the people that conducted the study expected this, and we'll talk about that more in the appraisal. Okay, so once again, this is our formula we saw earlier for the flow of our participants. So this next chart is actually talking about all of the indices that were measured. So you can see there's a lot of information here. I'm going to focus more on the ones that we found that were significant, and we can talk briefly about the others as well. So kind of starting here at the top, we have the SCORAD index. So this is a subjective index that's used to determine someone's score of severity for eczema. So based on how much itching do they have, how much of the rash affects their daily functioning, and then there's an objective score that's actually done by a physician that helps determine what the extent of the disease is on a physical exam finding. So both of these were used. We have a pruritus score that kind of falls within a subset of the SCORAD index, a subjective sleep score, which was done by the parents and a part of that questionnaire, sleep onset latency, determining, and these are all from the actigraphy, how long it took someone to finally fall asleep, how efficient their sleep was, how long they were awake in sleep, in that interval, total time slept, mobility, which is what Dr. Keyes was referring to, and then fragmentation index, which refers to fragments of how long they wake up, so total number of awakenings compared to how much they were awake. And then finally, those IgE levels, which are compared to the other objective severity of their atopic dermatitis. So of the ones that are here, the ones that were found, yeah. So the IgE levels were measured at blood samples at the last visit, 9 a.m. after. So once they've done a 4-week trial, they collected, the next morning they collected, at 9 a.m. they collected the IgE.
So after a period of trial, they got 4 weeks of whatever medication, then the next morning at 9 a.m. they would get their blood drawn and measure the IgE levels.
So at the end of each 4-week trial?
Yes.
So I can't just put my kid in this study and sit on them, you're going to poke them away.
Yep.
Okay.
And that may have been another part of why those may have turned away from it. Okay. Actually, that may actually account for the 10 that were lost at phase 1. Maybe they didn't understand that there would be a blood draw and then pull out. But interesting point. Anyway, moving on to our p-value. So the 3 that were found to be most significant also happened to be the 3 pieces of information within the study they felt that held the highest priority. So the scored indices going into the study were predetermined to be the most significant indicators on whether we had seen any improvement or not, and then as well as sleep latency. And whether you want to call it convenient or not, those are the ones that were actually found to have p-values that were significantly significant, to not be redundant. So looking at our means, and we'll start with the SCORAD. So here we have all of the patients. So it's important to remember in a crossover study, each patient actually represents 2 data points because they are tested twice. So every patient is here, and then there's a mean for each of those. So we have the before and after for each of the melatonin groups here, and then the placebo group is here, and they measure the difference in their indices here. And remember before we had talked about anything that was decreased by 5 or more was found to be significant. So the average among the subjective scored index for patients that received melatonin was nearly 10, with a standard deviation of 7.6, which actually is pretty large considering that puts a fair number of them in the insignificant range. But then compared to the placebo effect, you receive almost none of that with a large standard deviation. With the objective, we receive a little bit less of a difference, but fairly close. And then in comparison with the placebo, it has almost no effect. And then here is the difference of treatment effect from the mixed model. So this in itself is comparing the differences between the 2 groups. So the numbers may not directly add up, but the reason for that is because the comparisons and means do change a bit. So, and that's, you can see here, they found when comparing melatonin to placebo, specifically for their differences, that the mean falls here, which is significant when using their criteria for the study. The same thing for the objective at 8.7. And then lastly, we're going to talk about the sleep latency. So they found that sleep onset latency before use of melatonin for these groups was at nearly 45 minutes with the standard deviation of almost 40. So we're talking kids that may be up for over an hour after. And then after use of medication, that is cut in half effectively. Whereas patients in the placebo group had almost no change, only about 2 minutes. Or even less than that, only about 1 minute. So, and they found that to also be significant. Okay. So I know we covered a lot there. Any questions about that?
Do you want to start picking apart these numbers now or later?
No, that's the appraisal. We're almost there. Any other questions from non-Dr. Whalen? Okay. All right, so now we have some charts to explain all those numbers. So our first chart here talks about the scored index, and it kind of just makes an illustration of what we just talked about. So our filled-in dots are the melatonin group based through their study, and then the dots that are not filled in are the placebo. So you can see here from pre-treatment, our melatonin group starts at a higher index, and then over the period of time decreases, as we expect. And then here, with the placebo group, they have almost no change at all. I found it interesting, although I don't think it really means anything, that our pre-treatment groups actually start a little higher than the placebo does, but I think that's me just trying to find a pattern in nothing. So then going to the objective score, it's very similar to the scored index. The sleep latency is the one I think that is really that sticks out. And you can see here these outliers here, these determine our first standard deviation. So you can see there's such a difference, but even even within that, there are pre-treatment groups for melatonin groups. I mean, they have such horrid latency, and then it improves so much after treatment. The last thing, this actually takes into effect the treatment sequence, so this is the mixed effect model. So what they did here is they took the patients that actually received melatonin first and compared that group to the placebo group. So this is actually, group A versus group B, and then they broke them down again and did group B versus group A when they crossed. So you can see that patients that started with melatonin, then went down, whenever they were put back on the placebo, they actually rebounded quite a bit. They were even above the score that they had previously. And then moving from our patients that had pre-treatments, post-treatment from placebo, then moving over to their melatonin, they actually had a more significant decrease in their scored index. We're kind of thinking this may have to do with more than just the medication, but the fact that they had much longer to establish those appropriate sleep cycles. They had more time to keep a diary and learn, better sleep hygiene. So that may play into why there was a more dramatic decrease. Okay, so now we're going to move on to the appraisal. And this is the part where you get to interact and answer questions. I hope you're ready.
So what question did the study ask? Anybody?
Why did they do this study? What were they looking at? Were they trying to prove?
Okay.
And we're going to pick on you.
What are we saying? That's the question. So they're trying to see if melatonin, so they're saying that kids with eczema sometimes have sleep issues associated, and they question whether melatonin can independently help improve their eczema if they have some anti-inflammatory properties.
Yeah, that kind of sums it up. Good job. All right. So
is it well documented? It's not surprising to me, but it is well documented that eczema is significant sleep difficulty.
So, yeah. Oh, you weren't here at the start. Okay, so the start, prior to 2014, there was really no evidence at all correlating eczema and sleep disturbances. But the same group that conducted this study in 2014 conducted a study that was published in Pediatrics relaying decreased levels of nocturnal melatonin levels in patients that have more significant atopic dermatitis. So they thought it was interesting, and they also realized their patient group was actually already on melatonin, but they had no reason why other than, oh, well, they have sleeping difficulty, but maybe there's a reason. So that's how this study actually formed to see if the treatment would work.
Intuitively, it seems reasonable.
It does. Yep. Okay, so.
Did this study answer this question?
Just have to read from up there, the computer.
Yes or no?
Our computer died. You got 50-50. Anybody? Student? We have any students?
Yes.
Yeah.
Yes. Good job.
You did it. Yay.
Yay.
All right.
Okay. So was the assignment of the patient to treatment groups randomized? Dr. Davis discussed this earlier. Yes.
Okay.
Randomization was computer generated in groups of 4 by personnel that had no further involvement in the study in order to maintain blinding and prevent any biases. So were the groups similar at the start of the trial? Sam's saying yes.
Yeah.
So yeah, as we,
you can go to that.
We'll go into this table later. Okay, so were the groups treated equally? Yeah, so we remember these groups, they had both treatments after having a washout period in between, so they were treated essentially equally. This is the table that you can see. So the big thing I want to point out here is you can see that the two groups, if you look at melatonin and the placebo columns, they essentially had a similar age. The ages were both in the 7.5-ish. And then they had all the numbers going down, which are the means. So you can see the averages of everything were similar. Computer's frozen.
Oh, you're fine. Oh, yeah.
I don't remember the rest of it.
Yeah, so something else that's interesting to bring up is here, and we'll talk about this more in the critiquing, something we found interesting, though, was that you have a mean of 7 years in this wide range of 1 to 18, but the standard deviation is only 3.7. So, I mean, really limiting that, that puts everyone somewhere between 3.5 to maybe 11 years old. So we know a lot of our kids that we treat with eczema, I mean, they're falling in the, 6 months to 18 months, 24-month range. Those are the ones that are really affected because those babies are up all night crying, they're constantly scratching themselves. So we found it interesting that there's very few data points on that population specifically. And that may have had to do with issues trying to get participants to actually be in the study.
The other thing to consider is the table doesn't say anything about their ethnicity of the patients, so that's something that you want to keep in mind because the study was done in Taiwan. So the internal validity, were all the patients who entered the trial accounted for, and were they analyzed in groups to which they were randomized? We have a couple heads nodding yes. So yes, the patients that were excluded were accounted for and were not used in the analysis. The study was prepared to meet a minimum number of participants in order to retain 80% power, and this took into account the amount of patients lost to follow-up in the study. In fact, those conducting the study prepared the trials based on the assumption that there would be a significant number of patients that would be lost.
So to make sure you guys are following along, so when I first read this, I kind of thought, well, this study doesn't seem like it has a whole lot of power. And I instantly attribute that to, this isn't a large study. This is a small study down in the middle of nowhere. So, relative to me anyway, I shouldn't really talk, though, being from West Virginia. But
It wasn't done in West Virginia.
Yeah, but I digress. So my thought was, well, this study would probably be much better if we had more power. However, when you really look at the data, because of the crossover effect that they use, they doubled the data itself. So like I said once before, every patient was 2 data points. So they knew ahead of time that they were very likely to lose patients based on cultural preferences. So in order to keep that power there, they plan ahead of time to do a crossover. This is a very smart move, especially with a randomized clinical trial. So this study actually holds its own for this, despite having less than 100 patients in the study, or even less than 50. So, okay, sorry.
Were the measures objective? So was like the study blinded? Yes, we have a couple people nodding. Both patients and clinicians were completely blinded to the treatment groups and their randomization. So how large was the treatment effect? Was it little? Was it large?
Does anyone want to agree with Dr. Whalen? Not agree? Just say anything else you'd like to say? Other words? No? Very talkative crowd.
The only other thing that struck me about the numbers is that you had a pretty wide standard deviation, pretty wide.
A lot of them crossed over each other.
We're getting there. So we're getting there. No, you're okay, but you're right on track. Like that's actually right where we're about to talk. The very next question actually talks about that. So.
Okay, so the treatment effect was large enough to be considered significant for the SCORAD subjective and objective, as well as the sleep onset latency. These factors were considered the most important measurements in the study. However, there were multiple scores that did not show a significant treatment effect, which Chucky went over in the tables earlier, where you could see that there were.
Yeah, so
we'll get there.
Oh yeah, we do have the table. We'll go over it again. Yeah.
It's the next slide.
Okay. All right. And then.
And how precise was the estimate of the treatment effect?
We kind of already talked about this.
So while the standard deviation of the treatment effect difference for SCORADs and objective SCORADs were fairly narrow, indicating a precise estimate, the standard deviation for sleep onset latency was fairly large, meaning it probably wasn't precise.
Yeah. So when you look at the actual difference in treatment, and we'll pull this up. Yeah. So when you look at the difference in treatment effect using the mixed model, really putting all the data together and comparing, the means for the both of the SCORAD index and the objective SCORAD index, their standard deviation in itself is not greatly large. I mean, that shows the total range there, but in itself, it's still close to that area of being significant at 5, even at the lowest point. where the vast majority of it is above that, which is why it was found to be statistically significant. But when you look at the next one goes, when you look at the sleep onset latency, I mean, purely comparing those, there's so much time. I mean, that effectively says that kids that were taking melatonin versus placebo gained anywhere from 4 to 40 minutes difference in their sleep. So that's a wide range. I can't say 4 minutes makes a real difference, right? Especially whenever total time amount of sleep is actually not even found to be significant. So that's why I think that the sleep onset latency is not as precise, whereas the indices
that
were.
one almost looks like apples to oranges, because you would expect the before melatonin to be similar to the before placebo, and you're already starting off with 45 versus 31 there. So I'm not surprised that the latency didn't change. So the placebo looks like it was a placebo. You went from 30 to 30 before and after. But why wasn't the before melatonin similar? Somehow the placebo group was, I don't know how significantly different they were, but the before group and the placebo and that measure was not similar to the before group on melatonin.
Right. And I think that's why you see such a large difference when those two are actually put together and compared in the difference. I think that's what leads to not as a precise difference.
Big variability. The two groups by themselves are not nearly as comparable as a lot of other things, and it's just a little bit odd. But then, I've got one more comment I'm going to say, because you're probably going to cover.
Maybe not. Okay.
Okay, so will the results of this study help me in caring for my patients?
So this is really the meat of this. We really want to use the data.
What do you guys think? Is it going to be helpful with our patient population? Dr. Burt was shrugging his shoulders, possibly.
I mean, maybe you could pitch it as yeah, there's some possible small study fringe benefits. He's interested in melatonin anyways with eczema, silver lines.
Yeah, I think from a practical reason, a lot of these kids were already treating anyway. So I think you have to look at it now. We have evidence to support, if you do accept this, we have evidence to support what we were already clinically doing.
So it's cheap.
Yeah.
Widely available with a good side effect profile.
So to go further into the external validity, though, do you feel like the patients that were in the study are going to be similar to the patients that you see in practice? What do you think?
Here in Roanoke, Virginia.
Well, yeah, aside from ethnicity, we'll exclude that. We have much more diversity here. But yeah, age, and then, of course, if we're thinking about the group that was chosen for this study, having... Exactly. So, yeah. So I would say kind of. They do match, but that we do have to think about the fact that the diversity here is going to be different. And also that age range we talked about before. A lot of the kids we're seeing, I mean, we're seeing kids that are 6 months, 8 months that have severe eczema. And there's no data here to say, well, is it actually going to be safe or anything to give those kids melatonin? We don't even have data to support that, so it doesn't help there.
Is the treatment feasible in my setting? Yeah.
Yeah, Matt
We have a
covered
couple
that.
people.
Yeah.
So does possible benefit of treatment outweigh the potential harm? And we kind of talked about this too. Yes, you want to keep in mind that no kids less than 1 year of age were included, so would this affect their growth and weight gain if they're sleeping through the night and not getting their nightly feeds?
Yep.
So the study can be applied to my practice. Yay.
Yay. Okay, so these are conclusions of the study that were made by those that did the study.
So statistically significant evidence found to support that melatonin had a decrease in both subjective and objective SCORADs, as well as improvement in sleep onset latency. No statistically significant crossover effect found between groups, so no difference in data whether the group was on melatonin or placebo first. And no adverse reactions or events were recorded. In summation, melatonin was found to be a safe and effective means to improve sleep onset latency and disease severity in children with atopic dermatitis.
Okay.
So are we going to accept or reject this study?
What do you guys think? Like it? Pile of crap? Anyone? Something?
I think we accept that.
Yeah.
I think so too. Yeah.
We agree. We want to see a larger study in the future, hopefully with more results that can help us support
Yeah. So a couple of things to add for improvements.
You want to go? Okay, during analysis,
go ahead, sorry.
we're both doing it together.
Yeah.
During analysis, collecting raw data and determining the number of patients that actually had a statistically significant improvement compared to those who did not in both groups could have been used to determine the relative risk, absolute risk reduction, and number needed to treat. This information would have provided even greater support for conclusions drawn at the end of the study. A future study incorporating more demographics across the developed countries will help solidify results of the initial study.
So let me just be the first to say I was thoroughly disappointed that I had no raw data because I was going to make everyone do number needed to treat, and we were going to sit here for several minutes until someone gave me an answer. But they didn't provide it, so you got lucky. So anyway, really the fact that we don't have that, I think they can justify it because the way they had done the study needs to use means, but it would have been nice to have had the data available. Okay, so for those of you who don't know, I have a new baby. They're on the right. That is my other fur baby. That's Tot or Totsie.
Similar breed?
Yeah, she's a Morkie.
She's also cost $14 trillion.
Not quite. I got a discount.
You didn't change the number though.
Yeah.
I have a question.
Yeah.
I'm not familiar with using SCORAD scoring.
Yeah.
So if they went from like a 49 to a 40 and then the objective was 30, like what is a 30 score? What does that look like?
Yeah. So sorry, we can talk about it. So subjective scoring, they had a cutoff for it, but really I look back, the scoring can be very high. I think up to like 150. It's a huge questionnaire that's used, and kind of like anything else that we use, like a Vanderbilt assessment, or if we do like a depression screening, a point scale that the parents are used, and those are what are commonly used in offices versus an objective one. Objectively, we just say, okay, you have eczema or not.
Right.
So the subjective SCORAD can go up to 150. They chose 105.
103.
Well, 103 is the one that they chose.
1 to 1.
Yeah.
Okay.
So they chose 103 as their cutoff, or that's the most severe we want to see. So in the higher up you are, the more severe your disease is.
Right. So if I look at a kid that's 49, am I like, golly, that's a lot of eczema? Or am I like, man, like what is that kind of, is that really bad? That's halfway up the scale.
That's a good question. I would think because of the minimum criteria used for the patients in the study and showing the average there, as well as taking into account for just demographics, eczema is a huge issue in Taiwan. Yeah, so taking that into account, I would say at minimum it's moderate.
Okay.
But that's just me spitballing. No, that's not I have no evidence to back that. So.
I got you.
Okay. Any other questions?
So I just want to, kind of bring that. That's a really important question because then it's when we go back to what is clinically significant versus statistically significant. So do we really care about the difference of 10? Is that going to make the baby really much better? Can we really say this is improvement? In the article they put significant improvement, great, absolutely wonderful improvement. I mean, is that really that wonderful? From going from a score of 47 to going from a score of 37, is that really that wonderful? Are they giving too much price to the difference? Since the total score is 103, all the way from 1, I mean, is this really, really that impacting? I think that's a really important question to ask, but honestly, the whole questionnaire, it's like when you have level 0, 1, or 3, and then you give a number, and then you add on the number. We don't have that to evaluate that deeper, but I think it's a really fair question to ask. Is this just only statistically significant, or is this really clinically significant? And I think on the onset of the sleep might be for those who are sleeping 20 minutes earlier, because a baby not falling asleep, from 40 minutes to actually go down to 30 minutes or 20 minutes, that's significant for the parents, so the onset of the sleep might be significant, although, remember the confidence interval when on the goes to 4 minutes. So 4 minutes might not make much of a difference. But in general, the mean of 20 minutes. So most kids will actually decrease the life of sleep of 20 minutes. So I think on that particular sleep latency question, I think that was probably clinically significant, even though the spectrum was so big, versus the scoring. I'm not so sure because I don't know exactly.
I found some calculator online, but that doesn't, it's not like pictures.
And just to add to your question, this is the extra question I had that we didn't include here. They chose 5 as their cutoff to say it was statistically significant. No explanation why 5 was used as the number. No idea why 5. And it's, once again, like, if scale is 1 to 100, if 5 is the difference, I mean, what are those proportions, like you said?
Yeah.
I have no idea, so.
And honestly, I thought on the supplemental information, I thought they were going to show us the scores, but no, it's not there. I downloaded it, it's not there.
So those were some of my, so the scoring system is not like something well known that you guys are all using in clinic right now with the score assay?
No.
But it's a validated system? I mean,
it is.
They made it sound like it was good because they did it twice, the parent one and the physician one.
They funded it. Yeah.
So it seems reasonable to me that that's potentially a validated score and something that some improvement after 4 weeks of very benign therapy, that seems very reasonable to me. The whole sleep side of it, I bet you there's no validation of throwing Fitbits on kids and interpreting the data. I bet you there's no validation on that. So, and as Don said, and none of us are surprised by, trying to figure out what wiggles and bumps and beeps the Fitbit is picking up on and how it's interpreting them and applying that to anything is very difficult. And the one thing that, so at best, getting sleep information out of a Fitbit in kids is an unknown. And that was the one thing they said it improved on was the one thing that had the oddest apples to oranges comparison at baseline. So from a sleep point of view, again, intuitively, it kind of sounds reasonable. Eczema is the itch that rashes. If I'm sleeping a little bit faster or a little bit deeper, even if I can't measure it, I'm going to cause less rash. So again, seems reasonable, seems safe. Not surprised that they can't really quantify too much from sleep yet, short of putting all these kids on true polysomnograms. But I thought it was a nice result. But it shouldn't be hard to get a bigger study and do it longer.
And I think that's what I would like to see.
And
more.
Get the IgE poke.
I think the IgE
increase your compliance or your people to stay in by that seems totally unnecessary.
And the other thing, what you're talking about, the fixing, versus real sleep studies, right? The real sleep study documents did not find any difference. So when they did the real sleep studies in filter, because not all of them have it, and they compared the data, they didn't really have much of a difference.
So has anybody compared the Fitbit to the polysomnogram?
That would be a good question. But when they did that little analysis, when they took the polysomnography and related the data between the two, they didn't really find much of a difference. But they didn't put that in everybody. So they couldn't really make it a big deal because not every single kid got it, so only a few of them. So they just put that like a side note in the last one of the paragraph, but it wasn't one thing they could really analyze or relate or correlate.
All right. I'm going to go ahead and see if anyone has a question on the line. I'm going to open up for conversation.
The conference is now in talk mode.
Okay. Here's your chance. Going once, going twice. All right, bye-bye.
The conference is now in silent mode.